and welcome to Wellness Live. My name is Dr. Olivia Moses, and I will be your host today. And this broadcast is brought to you by the Living Whole Wellness Program right here at Loma University Health. Well, we are so glad you joined us today, and we are talking about actually a topic that I'm fascinated with. You've probably seen all kinds of articles, and gut health has become a very hot topic in the press. And what we are seeing is that the gut is actually central to a lot of different things in our life and not just eating. And so the question is, if I have gut issues, if I have challenges with my gut, if I'm concerned about the gut, what can I do to kind of help my health? And we're going to be talking about nutrition and other things when it comes to gut health. And we have a very special guest with us today. His name is Dr. Douglas Nguyen. He has been with us for about 3 years here at Loma Linda University Health. He is a professor of medicine here in the Department of Gastroenterology. So before I turn it over to him, I want to share with you, if you are watching us live, you can ask him questions right now. So in the comment section, go ahead and type in your questions and we can ask him live on the air. So without further ado, I'd like to introduce you to Dr. Douglas Nguyen.
Hi, thank you so much, Olivia. Thank you so much, everyone, for carving out a few minutes of your lunchtime to visit with us today. And I think it's so important to really discuss something that's really important because you're right. Like, we are what we eat, right? Our health is what we eat. So I have the opportunity of actually being in gastroenterology now been practicing for over a decade now. And so there's a lot of different medications that have come forth for treatment of various condition as it relates to the gut, including irritable bowel syndrome, Crohn's disease, things like that. And but I wanted to sort of step away from that and kind of focus on how we can use nutrition as potential therapy for some of these chronic GI condition or gastrointestinal conditions. That will be kind of the fulcrum of my talk today. I just wanted to highlight 3 common conditions that I see in my own clinical practice here at Loma Linda and in GI in general. And I wanted to sort of highlight how we use nutrition as primary therapy to treat some of these conditions. I'm super excited to go over them with you. It's going to be a case-based discussion. We'll be highlighting 3 different cases, and I'll stop in between the cases to open it up to see if there's any questions that the audience may have. Okay, so today's program is very simple. The question is, can we use nutrition as primary medical therapy to treat common medical condition, common GI condition? And again, this is a case-based discussion that we'll be going through today. So the learning objective is really simple. First is to identify nutritional challenges in various GI conditions that I'll highlight today, and then also understand how nutrition can be used as primary or maybe as adjunctive therapy to improve some of the patient outcome. So here's my first case, a 56-year-old female presenting into our clinic for evaluation of chronic abdominal bloating for 5 years. Very common symptom, right? Generalized abdominal bloating. The patient reports that she has visible distension of the abdomen with increasing belching, and she really can't identify any obvious food triggers for her symptoms. And she does have associated cramping and nausea when the bloating is worsened, and sometimes she does have sporadic loose stool as well. So you can see here, right? Very extensive workup because she is over the age of 45. We don't want to miss a primary medical condition like a cancer or a tumor. We don't want to miss ulcers. We don't want to miss some kind of enteric infection that could be that might be present as well. And we also know that, as patients age, there's also a risk for pancreatic insufficiency where they don't produce enough digestive enzyme. So that can result in some of these symptoms. So for this particular patient, a lot of things were done. So we did both an endoscopy and ileocolonoscopy on the patient. We also sent for stool testing, looking for parasite infections of this intestine. We also sent for a test called the pancreatic elastase, which actually measures pancreatic function. We also sent for a test called calprotectin. This test looks for sort of gut inflammation. It's a very highly sensitive test to look for gut inflammation. We also even did genetic testing to see whether or not she has propensity for gluten intolerance or gluten allergy as well. And all of these tests, including her stool test, her upper endoscopy, her colonoscopy, as well as a CAT scan, were all unremarkable. And the reason why we did a lot of this workup is, again, because she's over the age of 45. There's multiple conditions that could be present, and we don't want to miss some of these diagnoses. So she was given the diagnosis of irritable bowel syndrome, and the provider who saw her placed her on common treatments, so medicines that we use to treat irritable bowel syndrome. So dicyclomine to help reduce bloating and cramping, probiotics, and fiber supplementation. And the outcome for her is that she did have some reduction in her overall symptoms, but it's only 25%, you know? And so at this point in time, she comes to see us and say, hey, what additional therapies are available to her as additional treatment? And you can see here the condition of what sometimes term as irritable bowel syndrome. There's different subsets of irritable bowel syndrome, including visceral hypersensitivity, functional dyspepsia. Those are different subsets of irritable bowel syndrome. So when you see your doctor, you might be like, oh, I was diagnosed with, dyspepsia or visceral hypersensitivity. Is sort of a spectrum in terms of irritable bowel syndrome. The incidence is estimated to be very common, about 10 to 15% of the population. So almost 1 to 2 out of 10 patients could suffer from this condition. But IBS result in a considerable amount of healthcare utilization. So it contributes to a third of consultation in primary care practices, and more than 50% of our practice in GI and other subspecialty care involves a patient with a diagnosis of irritable bowel syndrome. And the cost to care for these patients is estimated to be almost $2 billion in the US annually. The hard part about irritable bowel syndrome is that it's often associated with very high morbidity, right? It reduces the overall quality of life because it's chronic in nature, and it can be associated with anxiety and depression because some of these symptoms, like the visible distension, the nausea, the cramping, can be very debilitating for many of our patients, resulting in anxiety and depression. The problem with pharmacologic therapy for irritable bowel syndrome is that they only address a single symptom, right? So if you have irritable bowel syndrome with diarrhea, we give you an antidiarrheal, right? But that only addresses one symptom. And very similar to the patient that I highlighted earlier, she doesn't just have one symptom. She has loose stools sometimes, she has bloating sometimes, she has nausea and cramping. So her symptoms are multiple, right? And the problem is that when you have multiple symptoms, you have to add basically one medication for each condition or each complaint that she has associated with her irritable bowel syndrome. And of course, this leads to polypharmacy, which we know is not good for our patient, which can lead to side effects because now you're not only dealing with IBS symptoms, but you're also dealing with side effects related to the multiple medications that we give to address the IBS. And so you can see here that about 70 to 80% of our patients report specific foods that could trigger their symptoms. And they said certain carbohydrates, like certain fructose or lactose, can actually aggravate their underlying IBS symptoms. And we also know that certain things like short chain fermentable carbohydrate, called FODMAPs, if you ever Google it, you'll see this whole concept of FODMAP has been consistently shown to aggravate IBS symptoms. So how does FODMAP work? So you can see here that when you ingest certain types of small carbohydrates, you can see here that what it does is it does a couple things. It causes sort of more recruitment of water into the intestine, causing more gut swelling. It also promotes bad bacteria to grow, leading to formation of certain gases like hydrogen, methane, CO2, that again can cause more fermentation, more abdominal distension. And this overall leads to distension, abdominal cramping, and in some patients, even diarrhea as well. So you can see here when we take out FODMAP containing foods from our diet, this leads to a reduction in this particular study, a randomized control study. You can see here lead to a reduction in many symptoms: bloating, pain, stool consistency, and overall, when you ask patients to actually grade their overall symptom, there's a dramatic improvement in the group that received the low FODMAP intervention versus a regular diet. So simple, right? Just making a little bit of a tweak to your overall diet, taking out foods that contain high FODMAPs can help reduce so many of these different symptoms, like bloating, pain, stool consistency, and overall GI symptom as well. So that was one study that I illustrated, but you can see here, there's numerous randomized control study assessing the efficacy of the low FODMAP diet. And in many of these studies, they not only looked at patients' overall symptoms, but they also look at certain things like small bowel water content um, on MRI, for example, looking at also gas production. So objectively, actually even measuring these things, and they found that the group that received the low FODMAP diet intervention have, again, dramatic reduction in many of these parameters: gas production, less water recruitment into the small bowel, noted, and less abdominal distension as well, objectively on, MRI, not just how patients are feeling. So my first case now comes to an end, and again, type in your question now, is my first clinical pearl is that the low FODMAP diet is a very effective strategy for many patients in the treatment of irritable bowel syndrome types of symptom. The cool part about this particular study is that it's found to be effective in both patients with both IBS diarrhea and IBS constipation. So this can really apply even if you have constipation or diarrhea. So irrespective of your symptom, it can help reduce some of your IBS symptoms by employing this particular diet. When we have patients go on a restrictive diet, we know that it can affect the immune system. It can affect the gut microbiome. So we typically don't have patients actually go on a continuous low FODMAP diet. One, it's impossible to go on a restrictive diet for years, right? But also, it might not be necessary or beneficial for other health reasons, because if you go on a restrictive diet for a prolonged period of time, it's also observed that you might have micronutrient or vitamin deficiency, certain protein deficiency as well. So in our practice, what we do is we do a food elimination phase that lasts for 3 to 4 weeks, and then we do a food reintegration phase over the course of 6 to 8 weeks. And of course, we counsel the patient through this whole process to make sure that we can identify foods that aggravate their symptom. And typically, what's observed across the trial and in our own clinical practice, there's typically only about 3 or 4 FODMAP containing foods that typically aggravate the patient's symptom. So after this sort of reintroduction period, many of our patients can successfully still have symptom control and still be able to integrate some of these foods that can contain some degree of FODMAPs as well. So with that said, I'll open it up to see if there's any questions before I go on to my next case.
Sure. Thank you, Dr. Nguyen. And we do have some questions coming through. So, I think you'd have to be living under a rock right now if you've never heard of a probiotic. So, they're infused in a lot of different things on the market. So the question is, what are probiotics and what are pre and probiotics and how do they benefit gut health? And I will go further into saying, because there's so many on the market, how does one choose?
Yeah, so that's a very, very loaded question, Olivia, because it's very specific, right? If you're
Mhm,
using a certain probiotic, the question's what are you using the probiotic for? So,
mhm,
for example, my children goes on a very particular diet probiotic during the months of September through February. The reason for that is there's numerous studies to show that in school-age children, certain probiotics can actually prevent upper respiratory tract infection and also reduce days missed from school. We live in a sort of a two working parent household. So my wife and I are always wanting them to not miss school. So we use a very particular probiotic for that very reason. For example, we have patients who have Clostridium difficile. It's a very common infection of the colon. It's highly contagious. It's really difficult to get rid of. We use certain probiotic supplementation like Florastor. There's also a commercially available one through a prescription called Vals, which actually helps replace certain bacterial spores within the gut to help reduce the incidence of the Clostridium difficile coming back and also helping patients get rid of that infection much faster. So loaded question.
mhm.
And I think when you're talking about probiotic, one is you really should ask yourself, what am I using the probiotic for, right? If you have diarrhea, for example, as a predominant symptom, taking a probiotic like Phillips Colon Health could really help you. But if you're saying, gosh, I have side effects from chemotherapy, what probiotic should I be on? That also hinges on the type of probiotic selection, because as you know, the gut microbiome is so diverse, and we want to make sure that we're using the right probiotic for the right medical condition. So
Sure.
in general, don't recommend a probiotic if you're saying, I just want to take it for overall health, but it has to be specifically applied to a certain condition. Regarding prebiotics, so for example, the low FODMAP diet also, because of the diet that's involved, it does alter the microbiome, right? Because again, you are what you eat. Your bacterial makeup is what you eat as well. So again, there's certain diets that can help reduce gut inflammation, help promote certain good bacteria to grow. And the low FODMAP diet has been shown to also help alter certain bacterial signatures, if you will, when applied as well too. So those are also, some concept regarding pre and probiotic. And probably the next time if you invite me back, I can probably just do a whole presentation on probiotic and prebiotic. But it's a little bit hard to just pick out a certain one. But like I said, it does apply to that specific medical condition that you're really addressing. Is how I typically guide my patient on probiotic selection.
So, would you recommend having a conversation with your doctor before you start using a probiotic? Because
Absolutely.
how would one know?
Yeah, absolutely. And it's important to do so because one, the probiotics are very expensive, and two, what is the end result that you're hoping to get
Mhm.
to, right? So
Mhm.
so not all probiotic would be like, oh man, it's going to improve my overall health. Maybe, right? Maybe, but that's still a big question mark. And they can be really expensive, particularly if we're not pick like I said, I picked one for my children specifically during the winter month to help reduce respiratory infection. I know something that you take orally that prevents respiratory infection, but and we have patients who undergo chemo and they're having side effects. Yes, we do pick a certain probiotic that could help. Or people with C. diff, we do pick a certain probiotic. So yes, before you do make that probiotic selection, definitely consult with your healthcare provider and also ask yourself, what am I using the probiotic for?
Great. We did have a question. Actually, it's a follow-up question to kind of what you described from our YouTube audience. It says, which probiotic is good for upper respiratory infections?
Oh my goodness. Okay. So this is actually in children. So the one that we and it's school age children, so kids, under the age of 12. There's been numerous study and it's actually the kefir unflavored yogurt and it's one supplement a day. Yep. So that's the one that I use for my children. Yep. And it has to be the unflavored one because the flavor, as you know, they get rid of the bacteria and then they add back the culture. So it might not be, it's a little bit of a different makeup, if you will.
Another question is there a good source for seeing which prebiotic should be used?
Yes, it depends. So for liver health, for example, we give a prebiotic called lactulose, which helps actually cleanse out the liver. It's a prescription, helps facilitate bowel movement to get some of that waste from our blood, if you will. So that's one. And then certainly if you have bloating or gas, we would focus on different prebiotic, like Consul, for example, has a great prebiotic properties as well. And then of course, certain tweaks in your diet can also serve as good prebiotic.
Okay. Well, we have a lot of questions coming through, and I know we have to get to the rest of the presentation, but one
Yes.
more on the FODMAPs because we have a couple of questions coming through on that. Is where do I get more information? And if I want to start doing that, can I do it without a doctor?
We want you to, if you were to consider the low FODMAP diet, it's definitely something that you can employ. There's two really great websites from Johns Hopkins and Stanford University and Monash, which is where it's actually originated from. It's actually an Australian university. So Monash University, looking at sort of their low FODMAP program. When we do that, we do recommend a complete elimination for no more than 3 to 4 weeks, like as I illustrated. I think the hard part for patients doing that reintegration and really working with the healthcare provider, because you also don't want to go on that restrictive diet for a prolonged period of time without seeing clinical benefit. And also you're going to have micronutrient deficiencies when you're going on a prolonged sort of restrictive diet. So we do want to work with you to help to make that sort of a food elimination, food reintegration process a little bit sort of easier to deal with. But a good way to start, if you want to, is to look at some of these websites that we've mentioned, and doing that elimination for 3 to 4 weeks and see if your symptoms do improve as a trial.
Okay. Well, let's get to the another part of your presentation.
Yes, so many parts of my presentation. So let's see. I'm gonna pull it back up here. Can you see my screen?
Not quite yet.
Yes, let me share. There it is. Let
There
me
we
get
go.
back to my second case here. Put it up on the full screen. Looks like we might not be able to get to the third case, but I wanted to do a second case here. So case number 2, this patient says, I can't swallow. So I have an 18-year-old male presenting to the emergency department with a food impaction, so food getting stuck in the esophagus. And the patient reported that, hey, I ate my hot dog too quickly and I got stuck. But if you ask the patient further, he said that, gosh, in the last 3 years, I've been having a lot of difficulty with solid food. He does have a history of allergic rhinitis, so sinus issues, but he reports no weight loss despite the difficulty swallowing. So because the food is stuck, we want to make sure we remove the food, because if we don't remove the food, the patient can actually aspirate the stuff in the esophagus into the lung. So we did an endoscopy urgently, and you can see here, this is the finding of the endoscopy. So he has what we call trachalization, so lots of scar tissue, these whitest exudates, lots of inflammation within the esophagus. So this patient has a diagnosis of eosinophilic esophagitis. And sometimes it can be, people sometimes get mislabeled as having anxiety when they have this condition, like, oh, I can't swallow, but it's really a common condition called eosinophilic esophagitis. We actually see an increasing incidence of eosinophilic esophagitis. Older studies said it's about 60 cases per 100,000 patients. We think that number is actually a lot higher. Sometimes people also get misdiagnosed with something called acid reflux or GERD. So definitely get evaluated if you have symptoms of like heartburn or chest pain, not just food impaction. But again, this is a allergic antigen mediated problem that causes swelling of the esophagus, and over time they can develop scar tissue. And in children, it can cause dysphagia, almost up to 90% of those kids. You can see here that we have a lot of different medications nowadays, some injectables, some corticosteroids to help reduce the inflammation of the esophagus. The problem is that these medications have a lot of side effects. So, for example, corticosteroids can lead to risk for diabetes, can lead to risk for cataract formation, can lead to weight gain, mood changes, and many of these medications are not FDA approved to be used long term, particularly corticosteroids, to treat this condition. So this is where that 6-food elimination diet comes in. So you can see here, by doing a 6-food elimination diet, many of these patients can actually restore improvement, if you will, in inflammation. This is truly an anti-inflammatory diet. Um, um, and they only have to do this over the course of 4 to 6 weeks. And you can see here that many of these patients are able to achieve inflammation control. And again, this is looking at symptom score for difficulty swallowing, chest pain, nausea, also dramatically improve with this 6-food elimination diet. For many of my patients, particularly my young patients, it's hard to do a 6-food elimination diet, right? Taking out certain things like gluten and dairy and nuts and shrimp, things, shellfish, things like that, right? It's hard. So you can see here that perhaps many of the cases you don't have to. You can probably start off with a 3 or 4-food elimination diet. And if you don't do well, then over time you can do the 6-food elimination diet. But you can see here the success rate is still really high, over 60%, if you start off with just that 4-food elimination diet. And the 4 common food is dairy, gluten, shellfish, and nuts, right? So those are some of the basic things that you can do just to really help get inflammatory control. And you can also see here that in some patients who have a difficult time or have significant weight loss, I actually saw an Olympian, can you believe it? She won the Olympic gold medal several years back in water polo, but leading up to a couple of Olympics ago, she had 30 pounds of weight loss. For an athlete to lose 30 pounds, for me, okay, it's possible, but for an athlete to lose 30 pounds when she's working out and on such a regimented diet, I mean, we're talking about an Olympian. right? For her to lose that much weight over the course of 3 months related to this condition, we needed to be a little bit more aggressive with her. So we actually put her on something called an elemental diet. It's a commercially available product that basically replaces all of your meals and calorie and it has anti-inflammatory effect, not for just this condition. They've also looked at it for other conditions like celiac disease, which is a gluten allergy, and also other autoimmune condition of the gut, like Crohn's disease, for example. So you can see here that not only does she feel better with this, but also from an inflammatory standpoint, in what we call inflammatory cytokines, you can see here also dramatic reduction across the board with this particular diet compared to her baseline diet, right? You can see the reduction in the inflammatory cells. So my clinical pearl for this case is consider starting patients with eosinophilic esophagitis on a 6-food elimination diet. That seems to be the best, but if your patient can't do it, the 4-food seems to also be very effective. For more refractory cases, particularly if you have significant weight loss, you can consider that elemental diet to help reduce inflammation further. Yes. Any question?
Yes, well, thank you, Dr. Nguyen. And we do have some questions coming in. And one of the questions we have is, how do I monitor or track my gut health over time? And when should I see a doctor?
I think if you're having persistent symptoms that are lasting beyond 3 to 4 weeks, it's really important to seek medical care because irrespective of your age, you can see here there's various medical conditions that could exist, right? Irritable bowel syndrome, Crohn's disease, celiac disease, um, things like eosinophilic esophagitis. One of my patients was diagnosed with anxiety because she kept going to the emergency department with chest pain. All of her workup, including her x-rays and her blood tests, are always normal. And they're like, oh, it's just anxiety, but it's not. She actually had really severe eosinophilic esophagitis that causes nausea, that causes her heartburn and her chest pain. So definitely seek medical care when you have persistent symptom, particularly if they're lasting beyond 3 to 4 weeks, because it's something that definitely needs to be addressed. For example, even some patients who are like, wow, man, in the last several months, my bowels have become a little bit more irregular, right? So I'm getting a little bit more constipated. So this happened to one of my 42-year-old gentlemen, big polyp of the colon. Luckily, he came in for medical care because if he didn't, over time, that would have developed into a cancer if it wasn't addressed and removed at the time of the colonoscopy. So definitely, seek medical care if you're having symptoms that are lasting beyond 3 to 4 weeks. Yeah. So, and look for symptoms like that are a red flag: difficulty swallowing, persistent heartburn, persistent bloating or distension of the abdomen, right? Weight loss, unintentional weight loss, blood in the stool, changes in your bowel habits, either more constipated or more loose stool. Those are all the things that we can definitely track and seek medical attention early.
Okay, great. Well, we've mentioned a little bit about mental health, and what we're seeing, I think, a lot in the press and everything, this connection between mental health and gut health, and vice versa, gut health on mental health. Can you speak a little bit more to that?
Yes, there's a lot of studies that show, there's a strong connection between the brain and gut axis, meaning that the stress hormones that causes anxiety can also play havoc on the gut, but not for everyone. Right. And but it can certainly aggravate certain symptoms. So even autoimmune condition like eosinophilic esophagitis, or what I do in my own heavily in my practice is inflammatory bowel disease, like Crohn's disease or ulcerative colitis, definitely emotional stress, anxiety, poor sleep, believe it or not, are strong predictors of actually worsening inflammation within the gut related to some of these autoimmune conditions. So so part of our practice, even sleep habits are important. So when we see some of our patients, we talk about sleep habits and we try to get them to have better sleep hygiene because that we know that also helps promote better gut health as well.
Okay. Another question that has come through is regarding about simple actionable steps. Like if I just want a healthy gut, what can I do?
Yes. I think definitely increasing fiber intake it has been shown to really be really helpful. And the fiber that I really love is console. It's sort of a mixed fiber that helps that there is a good prebiotic property just overall for your heart health and your gut health. Um, so that's something that you can definitely do. Getting screening for preventable medical condition. You know, the American Cancer Society recommend getting colon cancer screening starting at the age of 45 for many of our patients. And, you know, colon cancer remains one of the leading cause of cancer-related death in the US among both men and women. So that means we're not getting all of our 45-year-olds screened. And particularly in Southern California, believe it or not, we actually have the highest incidence of advanced colorectal cancer compared to other parts of the country among younger patients. So again, we're doing a really good job for our 50-year-olds. We need to get our younger patients screened as well, right? Just like when you're talking about pap smears and mammogram, definitely don't forget about colon cancer screening. And then also get a good family history. Like know your family because many conditions run in family, like pancreatic cancer, chronic pancreatitis, gallbladder disease, diverticulitis, things like that. Get a good family history so that you understand where your background is from, right? And so that you can actually help tailor your lifestyles and your health health directives, if you will, based on your not only your own history but your family history as well. So those are the things that I think are good ways to definitely get started to improve your overall health and gut health.
As a little extension to your last answer, I think when it comes to our gut health and our bowel movements or anything with the gut, it's very private and people get embarrassed and then they don't want to talk about it and then they sit and suffer in silence and then they definitely don't want to go talk to a doctor maybe they've never known before about these intimate things. Is there something you would say to that patient who is embarrassed and scared to even go in and talk about it openly?
Yes, millions of patients struggle with many of these different symptoms, as I highlighted here. One to two out of 100 patients, right? Um, I'm sorry, it was actually 10 to 15%. So sorry. So it's actually one out of two out of 10 patients, right? Actually suffer from many of these GI symptoms, right? And it may be irritable bowel syndrome. It may be another condition that that someone has similarly experienced, and we definitely want to work closely with our healthcare provider to really address some of these symptoms rather than live with them, right? I never believe that you should live with these symptoms because many of these symptoms can easily be addressed one way or another. And
Yeah,
then
and
also there might be an underlying condition that we don't want to miss, particularly if you've had more chronic symptoms lasting beyond 3 to 4 weeks.
And to all the potential patients out there, this is your doctor. They've heard it before. They've seen it's not nothing to be embarrassed about. This is their job.
Nothing.
This is
It's
what they
our
talk about
job.
all
Yeah.
day, every day.
And that's
Yes.
what we're trained to do. And that's what we're trained to do, right? And that's what we're training to help you address. It's too hard to navigate. You know, like I don't navigate my taxes by myself, right? I need a tax accountant. So, so just think of things like that, right? I don't try to do my own teeth. I have a dentist. So, I mean, you can't be it all, right? You can't be a mom, a grandma, a grandpa, a dad all the time. You might be really good at those particular jobs, but let your healthcare professional work with you, partner with you to really get some of these things addressed because it could be a simple dietary intervention. It could be a simple supplement. It could be a simple blood test that could give us so much answers and so much relief. Yep.
Well, thank you so much, Dr. Nguyen, for joining us today and for sharing your expertise with us. And to our audience, we always want to say thank you to you for joining us and being a part of the Wellness Live family. We want to invite you to our next session, which will be on August 29th. And our speaker will be Dr. Helen Hop Marshak. And she will be talking about something that you don't want to miss: nudge your way to health, how to make change last. You don't want to miss it. Well, again, I'd like to thank you. My name is Dr. Olivia Moses, and we'll see you next time.
Great. Thank you, everyone. Have a good rest of your lunch. Bye.
Bye bye.